Tracy Bird is Senior Advisor of Education and Consulting in our Kansas City location. Lynn Adams is Director of Education and Consulting in Hays, Kansas, in our Hays office. Combined, they have about 61 years of medical practice management experience, and tonight they're going to talk with you about bitter medicine. Tracy?
Thank you all for coming and being here this evening. We really appreciate your time. Can I have the clicker? I do need that. Bitter medicine. You might think that's a bit of an odd title for a program. And from a literal perspective, this is not what we're going to be talking to you about this evening. However, we are going to visit with you about the negative, inappropriate, and sometimes disruptive behaviors that occur in the workplace that undermine quality, that affect your revenue, and that increase your liability risk. Now, when Lynn and I were asked to come up with a topic for the program this year, we tapped our 61 years of collective practice management experience and compared practices that we had worked with over the years that we felt had been successful and those that had been less successful, and tried to measure the differences. Those successful practices had great teamwork, had very little turmoil, good communication. People truly enjoy working in those practices, those hospital situations. They had great patient satisfaction scores. They were successful financially, and they had all the correct systems in place to reduce liability risk. Then when we looked at the less successful practices, there was a lot of turnover, absenteeism, turmoil in the practices, poor communication, not very good systems, all of those. The major difference, however, were the individuals and their attitudes. A lot of backstabbing, sniping, bullying going on in those kinds of situations. So we had this great anecdotal information, so we thought we better go see if there's research to back it up. And in fact, there's overwhelming research to back up our theory that bad behaviors, negative behaviors in the workplace do undermine quality, affect your revenue, and increase your liability risk. And in your booklets, you will see we've put in there an assortment of articles to support that. Now, there is good news, and what we're going to talk to you about this evening is how you all, as leaders, can recognize the difference between an inappropriate behavior and when it becomes disruptive and needs some intervention. And then we'll give you some tools to take back to your own organizations to help you implement better systems. That usually always gets a snicker. But I am here to tell you that this really serves no good purpose in the workplace except hurt feelings. And it's this kind of behavior that we're talking about, these negative behaviors that undermine quality, affect your revenue, increase your risk. Now, let me set up a little story for you. Imagine you're a family practitioner working in, this actually happened out in western Kansas. Family practitioner working in his office, and his PA is covering the emergency room. And about 11 o'clock one morning, the patient presents to the ER with severe abdominal pain. So the PA works the patient up and confers with the practitioner, the physician. They decide to get some films, get some lab work, and admit the patient NPO in case later in the day surgery might be necessary. So fast forward to about early afternoon, patient's had the lab work, the x-rays, and says to the nurse, "I'm feeling wonderful. I don't have any more abdominal pain, and I am starving. Please get me something to eat." So this is what the nurse does. She writes in the record, "Regular non-constituted sweets diet, verbal order, doctor." So fast forward a couple more hours, And the PA comes along to check on the patient, sees this order in the chart, and writes this. That is not what we talked about. Cancel the diet order. This patient should be NPO. Later, after the physician has finished office hours, comes to the hospital to check on the patient. And this is what is written in the chart. This is not my order. Now, we agree that there has to be a correction, some kind of intervention there. But is this the way to handle this? No. This undermines quality. It certainly is a liability risk. And if this medical record looking this way were ever to be in a courtroom, a plaintiff's attorney would feel like they have had a very good day because they would be able to discredit the physician, the clinic, the nurse, the whole thing. So this is the kind of, we call this jousting or finger pointing. There are better ways to handle these situations. Okay, let's categorize some of these behaviors that we're talking about. The aggressive behavior is easy to spot. That's throwing instruments in the operating room. That's kicking trash cans, hurling insults, throwing charts, slamming doors, those kinds of things. Thankfully, that only happens about 2% of the time in the workforce. What we are more concerned with are these passive-aggressive and passive kinds of behaviors that become sort of insidious in our organizations. And when they become pervasive, and it becomes disruptive. And then again, we undermine our quality, affect revenue, and increase our risk. So let me give you an example of a derogatory comment. Let's say we have an inpatient, and the physician has ordered respiratory therapy to come to show the patient how to do a spirometry. And the nurse is making her rounds and comes in the patient's room and says, "Has respiratory been here yet?" Patient says, "No, I haven't seen respiratory." That figures. They never come when we call them. I think they play video games and drink coffee up there all day long. Not good. Patient doesn't have a warm, fuzzy feeling about your organization, your hospital, with comments like that. I actually have a personal experience with a couple I will share with you. One, I went to a small practitioner's office, 6 waiting room chairs. I'm the only patient in the office. I sign in, sit down, wait to be called. There are 2 ladies behind the front desk. One is on the phone. When I'm sitting there reading a magazine, and all of a sudden she slams the phone down and says, "If that stupid patient calls one more time, I'm hanging up on her. I am not going to deal with that stupid woman again." And I'm thinking, now, was that a patient she was talking to? And is that the way they talk about all their patients at that practice? There again, and I want to let you know, we are not just talking about physician behaviors here this evening. These are the kind of negative, inappropriate, sometimes disruptive behaviors that go on in your workplace, and it could be your employees doing that. And it may be totally unbeknownst to you. You know, as a practice manager, it's our job to shield you oftentimes from that kind of behavior. You know, you don't need to be bothered with that. But it does go on, and it undermines quality, hurts your revenue, and increases your liability risk. The chronically late thing, my own former family practice physician, the last few times I was there to see him, I was waiting longer and longer in the waiting room to go back. The last time I was there, I had a 2:30 appointment, and he walked in the exam room at 6 p.m. So that is why he's my former family practitioner. It's those kinds of behaviors that drive patients away. He lost me and my husband as patients that day. Okay, so what effect do these behaviors have on the individuals in your offices? When you have folks that are working side by side with someone who is sniping at them or hurling, negative thing, making them feel less than they should. You have a breakdown in morale. You have a breakdown in communication. Nobody wants to communicate with somebody that's has negative behaviors. Those folks then become apathetic, and then they begin to distrust that the organization even cares enough about them to do anything. Nobody's ever going to do anything about these disruptive behaviors. Now, how about on the organizations? I mentioned before we have high turnover, we have absenteeism, you have low productivity with these kinds of behaviors, and you do have the potential for lawsuits. If an employee believes they are being harassed at work, they can bring a harassment suit. And if you don't have any systems in place or to deal with those negative folks, most of the time those people that bring those suits are going to be on the winning end of that. And I mentioned the absenteeism, and KaMMCO actually had an interesting situation that occurred a while back. From time to time, we get a demand from a patient. They'll write a letter themselves to KaMMCO, and they'll say, this particular incident occurred, and, I think you should pay me X number of dollars. So this incident occurred, and it involved a rural hospital, and we always investigate those things. So we sent some of our staff to this rural hospital to interview some nurses that were alleged to have been involved in whatever this particular situation was. And when we arrived to talk to those nurses, none of them worked there anymore. They had all quit. Now, we could speculate that perhaps the pay was bad and the hours were long, but I would be more willing to bet that there were some negative, inappropriate kinds of behaviors going on that caused those nurses to just throw in the towel and say, I am not staying here. Okay, how about the culture of the organizations? Every organization has a personality, and that personality is the culture. When negative, inappropriate, disruptive behaviors become the standard in an organization, you have a breakdown in morale again, you have horrible communication, and when that communication becomes a system-wide problem, that's when you really open up your liability risk. If people aren't talking together, things fall through the cracks, and that really increases your risk. People just become disengaged in what they're doing, and they end up just looking for the next best opportunity to leave. This actually happened to a practice that Lynn worked with a number of years ago. This was a family practice group of 4 physicians, and one of the 4 truly actually had 900 paper records, undocumented, stacked in his office. Not quite sure how he got in his office, but I think you would agree that this borders on disruptive behavior. I see some head nods. Yes, it does. Okay, what are the root causes of this behavior? Dr. Hoppick talked to you about, we have declining reimbursement. We're looking at a 29.5% cut in Medicare reimbursement. I was at a CMS meeting just today where they talked about the bundled payment program and the value-based purchasing program and this program and that program. I mean, they are just throwing regulations at us one after another. We have hospitals buying practices. We have practices merging together, so we have changes in leadership. This all causes people to be kind of cranky. But it doesn't give us license to bring those negative, inappropriate behaviors to the workplace and display them with our coworkers. We have family demands, the stress and the family pressures, the time demands. We're asking you all to see more patients and do it really efficiently with that great new EMR, right? More patients. And then, unfortunately, we do have substance abuse issues we do have to deal with. Drug and alcohol abuse, psychological factors. And, when you have a disruptor in your midst and you don't address that kind of behavior, those folks are eliciting the response they want, right? They keep doing it because they get what they want, and they do it because it works. We don't call them on that behavior. So why are we talking to all of you in this room this evening? Each and every one of you, those of you that are physicians, those of you that are non-physician practitioners, you are inherently leaders because of your profession. Those of you that are managers were hired into a leadership position. And it's each and every one of you that has the ability to affect change in your organizations. You've heard this idiom, one bad apple spoils the bunch. We've all heard that. This was a study done a number of years ago by a researcher who wanted to investigate what the results would be if there was a negative person involved in a work group. So what he did was he created 4 separate work groups, and in each work group planted a naysayer. And it was the same person he planted in all 4 work groups. And this person, this naysayer, would say, that'll never work. That's a dumb idea. Why would anybody do that? We can't. That'll never work. So what he found was in 3 of those work groups, everybody in that work group adopted that negative behavior. They became dysfunctional, less productive, all of those things. In the 4th work group, however, there was a different outcome. So as he began to look at that, he discovered there was one strong leader in that last work group. And that individual was able to counterbalance the naysayer. And this individual did that by listening carefully, by working behind the scenes to build the trust of the others in the work group, to be able to reframe those negative messages into positive messages, and to offer good working solutions. So it just proves our theory that it only takes one strong leader to be able to begin to affect change. All right. It does seem like an uphill battle sometimes. You know, why should we bother? Well, we bother because if we don't do something about it, the behavior just gets worse. And when the behavior gets worse, it undermines quality, it affects your revenue, and it increases your liability risk. There are also external reasons to do that. And one of them is we have peer organizations that are recognizing that we have these behaviors that need to be addressed in the workplace. On page 32 in your workbook, you'll notice that the AMA has a model medical staff code of conduct where they describe actually the disruptive behavior and inappropriate behavior. They describe disruptive behavior as abusive conduct that's verbal or nonverbal that harms or intimidates to the extent that it affects quality and patient safety. Those 2 things are compromised. The inappropriate behavior is conduct that is unwarranted, demeaning, or offensive, but perhaps unless it becomes pervasive, if it should become pervasive, then it becomes disruptive. So, and then on page 14 in that same booklet, the Joint Commission has in their Sentinel event alert also described, and they have mandated for their Joint Commission hospitals that they put policies and procedures in place to deal with these negative behaviors. And then we have the quality issue. You know, Medicare is moving from a volume-based purchasing system to a value-based purchasing system. And those of you that are working towards your meaningful use dollars or have been reporting PQRI or PQRS data know that quality is right there on the radar screen for all of you. And last but not least, we have the patient. You know, that's why we get up and go to work every day, is to take care of patients. The patient experience is extremely important and getting more important. And we want patients to have good outcomes, because when they have good outcomes, the data shows us that they are less likely to bring liability action. against our physicians. Now I'm going to have Lynn take over and talk a little more about the patient experience.
I'm going to recap a couple things that Tracy said that I think are important. We all work in organizations, and there are people there who do not behave as we would have them behave. And it's real easy to look the other way or ask somebody else to take care of that behavior. But we work in a hierarchical structure, and I think most people in this room would agree that physicians are generally at the top of that hierarchy. Somebody has responsibility for making our workplace better and providing better health care. And that's what happens. It falls upon physicians to do that. So this message is one that physicians can help improve our workplace for patients. Definitely do that. Let's talk about patients in particular. There was a study published in the Annals of Internal Medicine a couple years back. And not surprising, what the study finds is that patients rate the quality of care on factors that have nothing to do with technical skills. They rate care on these other criteria. And when you think about it, it makes sense, and we see how that happens. There is an expectation that healthcare in this country is always going to be at a very high level. That is a given. And so what patients tend to rate then as quality are these behavioral factors. How did my doctor speak to me? Did they listen? How was the staff? Was there parking? How long did I have to wait for my appointment? So these kinds of factors really tend to drive patients' perception of quality care. And what's happening right now as Medicare is moving from volume-based purchasing to value-based purchasing is these attitudes are becoming a component, of the reimbursement system. So let me show you something that's going on. This happens to be the Hospital Compare website. Don't know if you've ever seen it, but this is a CMS website. And what I did is I went out here and said, you know, I want to compare some hospitals one to another. And this is a consumer website. So I put in my zip code and I draw a circle around it and I say, okay, here's all the hospitals that are that are occurring in this circle. I want to compare this one to this one to this one. So I compared these three hospitals, and looking at the questions that come down, these are questions that have been developed across the U.S. that patients are asked about their experience of care. There's other information out here, how patients do with pneumonia in this facility, some other things. But this is the experience of care portion, and it asks things, for example, patients who reported that their doctor always communicated well. Well, in these three hospitals, they score pretty well along that 80% range. This question, for example, patients who reported that they always received help as soon as they wanted. This hospital, almost half the patients who were dismissed from this hospital said, you know, they weren't there when I need them. I rang my bell and nobody came. Now, if this was just information published out there, it may not make such a big difference. But here's what's going on in 2012. Medicare is going to take those hospitals that fall at the bottom of this and take a little bit of money away from them. And they're going to pay those hospitals that fall at the top of this list, that are the high performers. It's the Robin Hood effect that's going on. This is one small component of quality-based purchasing that Medicare is experiencing with. So let me take you a little bit further. This is Physician Compare website. This website, again by CMS, was launched January 1st, 2011. Right now, if you went out there to find yourself as a physician, you'll probably see your address. If you reported to PQRI in 2009, that information may be out there. But if we compare what's been going on this hospital side, which has been in existence since 2006, and try to predict the future on the physician side, what's happening to reimbursement, we will see at some point probably these factors reported in there and quality reported out on this website. Again, to drive consumers into the providers of their choice because they're given more information. There is a survey developed for group practices and clinics. Has similar, if not the same, questions that hospitals have. It is not a component of this yet, but in the future, looking ahead, it's not hard to imagine that this will be a component of reimbursement. The survey will go out to patients, they'll fill it out, and that data will be put on this website. I'm going to take you to another website. This happens to be RateMDscom. I don't know if you've followed what's been going on the internet. Whenever you Google a physician's name, you'll typically hit 3 or 4 of these websites where patients can go out there and score their doctor. And so here, for example, are 4 physicians from South Central Kansas. We have 2 doctors that score little happy faces and a couple doctors that have the straight faces. Now, here's what's really interesting about this. You click on the doctor's name, and here's what you'll typically find. Doctor's great, but new receptionist, rude and arrogant. Office staff isn't very friendly. 60% of patients seek the internet to help them with their healthcare decisions. And so when they go out there and find this kind of information, they are probably less likely to select a practice that scores low on one of these surveys, which really isn't a survey at all, right? It's just opinions, than one that's positive. And the interesting thing is that it's about staff and it's about behaviors that affect this. So I'm going to take you to one more website. This happens to be from the Kansas City area. This is the Consumer's Checkbook website, and this is a conglomeration of insurance companies, United Healthcare, Aetna, Blue Cross Blue Shield, in which they have sent this survey that's been developed to patients, asked them to respond about their providers. So they get it back, and these insurance companies are posting it here at this checkbook website. So I went there and thought, if I'm a patient, I might want to see an internist in Kansas City. So I put in a zip code, I could click 4 doctors, and I want to compare one to the other. So here we have 4 doctors. Now, I'm not a clinician, but I'm probably not likely to go see doctor number 2. But interestingly, this doesn't tell me where doctor number 2 studied, didn't tell me whether he or she did a fellowship, doesn't tell me anything like that. Strictly a rather subjective way of looking at that practice, and people will make decisions based on this information. Let me point out this one question there in the number 3. How often clerks and receptionists at doctor's office were helpful as they could be? We are talking about the organization as a whole and getting to those behaviors that are not, that drive patients away or that create this problem in our relationship with patients. Let me go talk about these patient complaints. Dr. Gerald Hickson is a physician researcher at Vanderbilt University. And over the past several years, since 1992 actually, he has done a tremendous amount of work in looking at claims, patients' complaints, and the physicians in the healthcare system. And this is a fascinating thing. What he's found is that 5% of the physicians in the system receive 33% of the patient complaints. You think about that. 5% of the physicians receive 30% of the patient complaints. And this is the really interesting factor, certainly from KaMMCO's standpoint. Of this 5%, they have the higher number of professional liability claims. So what's going on here? You have patients who have a lot of patient complaints also have more professional liability claims. Well, there is something going on right here. It has to do with things that happen before those patients actually bring a lawsuit. And there was a study done in Florida which went out and asked patients, why did you sue your doctor? So they got some information right. Some patients, they wanted retribution, they were angry, that sort of thing. But here were some other factors that they found. did not listen to me. Something happened, they did not listen. Showed little concern or empathy. Individuals had something traumatic go on in their life, and they felt that the person they looked to give them empathy and understand didn't give them back what they needed. Did not spend enough time, didn't answer questions adequately, appeared to be hiding something. Last week I got a call from a rural hospital. The administrator of the hospital took a complaint from a woman whose father had been in the hospital in the previous month. Her father was died. Her father was an 89-year-old gentleman that fell and hit his head on the dresser. He was also on Coumadin. He was brought to the hospital emergency department because he was bleeding profusely. They pulled it together, finally stopped the bleeding, and dismissed him from the ER. He was going out to the car, and he vomited. And the wound hissed. So they bring him back in the emergency department. They put gauze on it. They tried to stop it, finally got it to where it was controlled, sent the patient home. The daughter spent the next 3 to 4 hours keeping pressure on it and ice to try to get it to keep it from bleeding. Even at some point called the hospital so that they could get some additional gauze. Finally, about 4 or 5 hours after the last visit, the daughter called the hospital emergency department to talk to the nurse and said, you know, my father's still bleeding. Should I bring him in? And the nurse said, yes, go ahead, bring him in. And the daughter said, could you call EMS for me? And the emergency room nurse said, well, you called us, you can call EMS. Right? You know, we don't know if a case will come out of that, but now the patient's mad, right? Because of some behavior that somebody did. We also had another case. This was several years ago. Cardiovascular CV surgeon did a bypass surgery and the patient died. It's a known risk, of course, that's going to happen. We were deposing the family. The family said the surgeon said their mother's death was the responsibility of the anesthesiologist. And the surgeon compared their mother's death to the way inmates are put to death. You know, you think that might cause somebody to do something? And the other interesting thing is I was reviewing that case and looking at it. Those other healthcare providers that were in the depositions didn't have nice things to say about that person, right? That wasn't just an unusual one-time behavior. That stuff was going on regularly. And I'll have to say, most everybody in here, I've been in healthcare for over 20 years, and I've seen that stuff. Things that shouldn't go on. And when it doesn't go on, it needs to be addressed somehow, and that's always the challenge, isn't it? What do you do about it? Well, we don't do some things about it, and here's one of the reasons why. First of all, in residency, how many people went through some kind of program in which you were trained on how to confront individuals for their behaviors, right? That's part of residency training? No, it's not. So we don't have experience doing that. Also, there's a reluctance to approach it because when we touch something, we don't know if it's going to blow up in front of us. There's a lack of leadership. Not a lack of leaders. We got plenty of leaders, but people who feel empowered to stand up and go ahead and take care of it. And finally, we don't always have the certainty we need in order to jump into a situation. And conflicts of interest are often a very big item. And let me mention what those might look like. You have, for example, a ultrasound technician who has multiple registries. There's nobody in a 5-county area that can do all of the services that this ultrasound tech can do. But he's impossible to get along with, right? So everybody looks away. You don't confront that behavior. Same way, I worked in groups where there's one physician who is the highest producer in the group and may have some behaviors which are not helping the group get along. Nobody wants to confront that situation. Well, here's the bottom line, and this comes right from that Sentinel Event Alert on page 14, that organizations that fail to address unprofessional behavior through formal systems are indirectly promoting it. And I want to emphasize the formal systems. That is the how do we do this? How do we fix our organizations when they're broken? And there is a way to do that. First of all, you do need some kind of expectation, behavioral expectations. And that could be in a group practice on how we treat other people we work with, could be in a hospital. More and more hospitals are adopting these kinds of things. I think the AMA model behavior model code of conduct is really pretty good because it has some specifics. I wouldn't necessarily adopt it wholeheartedly because it would depend on which organization you're in. But there has to be some expectations of this is how we behave in our organization. And then you need some kind of policies. And over the next few slides, I'm going to talk about policies that exist. Again, these were developed by Dr. Hickson, which I think could be very effective of helping us to figure out what do we do when this happens. Leadership, we got plenty of leaders. We just need that leadership. And if we have physician support, and this is my experience in organizations that I've worked with, when we have physician support, we can get things done. Because if we have physician support, we have support of the organization. And if we have support of the organization, we'll have people who have the willingness to stand up and say, they shouldn't do that anymore. That person, that can't be done. That's not good for our organization. That needs to be stopped. Well, how do you tell, when does it cross the line? This is a very challenging situation. When does a behavior cross over from something you kind of go, oh yeah, that's just so-and-so doing that, to something that you need to confront it? Well, you need to look at how pervasive the behavior is. How frequently does it happen? It's happening weekly, monthly. You know, that plays a role. The duration, when an incident occurs, how long does it recycle in the system and become detrimental for how things happen? And what's the intent? I think about that individual who quoted, that came from the Texas Medical Society website, about, is there anyone on this unit who isn't stupid? There was not a good intent behind that kind of statement. That was only meant to demean and demoralize somebody else in the organization. And honestly, we really can't do that with one another if we want to provide good quality care. And finally, how is that expressed? We all get mad. You can't really change that. But from the event that occurs that ignites our anger and how it comes out of us, there's this space where we have an opportunity to do the right thing. And I think about that physician in that first instance who wrote, this is not my note. I can understand why that physician would be angry. Of course they would. But there should be a better way of dealing with that. And one thing about our healthcare systems is we often have methods of dealing with behaviors that do need to be stopped, through risk management, for example. We do need some other tools, so let's talk about those other tools. This happens to be Dr. Hickson's disruptive behavior pyramid. And I want you to imagine that this pyramid goes all the way down past the floor, representing the 90% of physicians who never need anybody to speak with them about about something they're doing. And from Tracy and my experience, this is true for any organization. It's not just physicians. A lot of individuals need feedback on their behavior so that they can improve them. So what Dr. Hickson has described here is this 4-step process, which starts with a discussion and then goes on to 3 other levels of progressive intervention to try to curb behaviors. So let me walk through each of those levels right now and talk a little bit about what happens in them. The first level is called the informal conversation. Also, he refers to it as the cup of coffee conversation. Now, what does this look like? Well, let's say, for example, a billing clerk comes out to the front receptionist and says to the receptionist, the next time you let a patient through here and you don't get their insurance information, I'm going to come out here and slap you silly. Well, I think maybe that person should be talked to. And how you do that, you pick a time, maybe nobody else around, and you walk up fairly nonchalantly, right, and say, I wanted to talk about that instance that took place yesterday when you come out the front office. In our organization, we don't want to talk to people that way. We think it demeans our organization. We're not as effective for our patients as we should be. I want you to kind of reflect on what happened, and if something like that happens again, how would you do it differently and how would you do it better? Now, I appreciate you're very valuable to our organization. You've been here a long time. You've done a great job for us. And so, please, we really want you to work on that aspect of it. Thank you very much. Don't need to document it. Don't need to get into a big discussion. You certainly don't want to get sidetracked. You want to stay focused on it. All right? You take care of that. That's going to take care of a lot of people. Nothing will ever come up again. So then the next level. Something similar happens again. This will be the awareness conversation. So in this one, you think, uh-oh, gosh, I got a pattern. I'm going to have to do something a little bit more. This conversation needs to be conducted by somebody who has authority. They're going to proceed through the same process. They're going to set aside a time. And they're going to call that person in and talk to them. And they're going to reassure them, if they are valuable to the organization, that they are valuable. But this behavior has got to stop. We can't have it anymore. Now, this is what I think is really interesting. Dr. Hickson's data suggests that almost 60% of the individuals who go through steps 1 and 2 never go on to step 3. 60%. Licensed individuals, whether it be physicians, nurses, technicians, they're all valuable to our systems. We can't throw them away lightly. We really owe it to them to try to bring them back into the system and make it all work. Of that 60% that never go on to level 3, that leaves, of course, 40. 20% of those individuals move on to another organization. They can't take the light. So then you end up with just 20% that would go on to the next 2 levels, and let's go through those real quick. Level 2 is the authority intervention. This is where the pattern persists. We've talked to you twice. The behaviors continue. This takes a little more work. You create some kind of an accountability plan. You're going to do an apology. We're going to have somebody shadow you. We're going to limit them. So whatever it is, some kind of limitation so that you can monitor and survey or actually create some kind of process where you're watching this individual to see that they don't do what they did before. There's going to be a timeline. We're going to follow up over this period of time. This is how we're going to know whether we have met the objectives or not. So this does take a little more work to put something like this in place. Again, it should be delivered in a supportive way, because I'll repeat, individuals are pretty valuable right now. They do a lot for our system, and we don't want to cast them away lightly. The final level, this is the level 3, this is the disciplinary intervention. This is often when you need a human resources professional or an attorney involved if you have a contract in place. But this is often where somebody might lose their job, might have their privilege restricted, maybe put on a leave of absence, but some concrete consequence that was discussed in the earlier intervention that comes to fruition right here. Now, it's been thousands of doctors that Dr. Hickson has looked at the data and come to this, and I think from my standpoint as an administrator, I always need to know how, I always need to know how to be consistent. And I'm really attracted to this process for dealing with it, because in this hierarchical structure that we have, the higher you are in the hierarchy, the more challenging it is to try to talk to you about behaviors that are going on. And it always works best when it's a physician-to-physician conversation. That always helps a lot. Okay, I'm going to wrap it up here pretty quick. A couple things I want to say is there is an evaluation in there that I want you to take care of. In particular, turn it over. We want to ask some questions about education that you might want for you and your staff in the future. And I'll leave you with this tonight, that I hope that you can take something away that can improve the quality in your organization, certainly improve your revenue, and also decrease your liability risk. Thank you very much.